This is Dr. James Fleming, and I am the speaker today. And from this, and I would like to start with my topic today is orbital foreign bodies. I'm Dr. James Fleming. I'm the director of the Hamilton Eye Institute at the University of Tennessee. And as a professor and a teacher, I always like to start with a case presentation to really let the audience think about what the thing we're covering today is. And there are a couple of questions in this. So let's begin this discussion of orbital foreign bodies. And case number one is a 55-year-old male. He was struck below the left eye with a single pellet from his partner's gun while he was duck hunting, a distance of 10 yards. Immediately his vision went to no light perception. His globe was intact. He had a 5mm unreactive pupil. On our initial examination, he had a 30 diopter left exotropia. This is the CT scan demonstrating the pellet that entered his right globe from the inferior portion, missed the globe itself, right orbit, excuse me. And as you can see, this opaque materials in a very interesting spot. If you take this CT scan and you put it three-dimensionally, as you'll see on the left side of your slide, there's a pellet in the back. We took the liberty of coloring the pellet. And if you can see this is pure orbital fissure, and here we have this pellet right in the optic foramen. So the question posed with a no light perception 30 diopter XT, to care for this patient, you would recommend A, exploration and removal of the foreign body, B, observation, C, steroid therapy, and D, MRI scan to assess the optic nerve. So I'm inviting the audience to participate and answer the poll. And everybody gets to do this, and I guess I do too, because it's in front of me also. And submit your answer. And we'll look at this, and I will proceed on, and we're going to look at this question a little bit later also. As you can see, the group, the host is sharing the poll results with us, and we have a pretty wide spread of treatment options that have been looked at. So I'll close this, and we'll move on to our next case. His case number 2 is a 9-year-old male that fell on a broken wooden handle 2 months prior. Wood was removed, and the wound healed over 2 weeks. He had new onset swelling and pain around that eye over 5 days. And this is the photograph, and I'll tell you, this is the original wood piece removed. 5 days later, you'll see the stitches in place, and the eye is now swollen. It had gone down previously. And so what we have is a new onset swelling and a wood handle that has been removed. So the case 2 question, the initial MRI did not show retained foreign body. Your next action is, with this 5 days out and new swelling, A, a repeat MRI is needed to find the retained foreign body. B, antibiotic treatment should clear this. Or C, exploration immediately is indicated. So everybody gets to vote and choose your first action. You may want to explore, you may whatever, all of these may be applicable, but I'm asking for what next, the first thing to do. And we'll see what kind of results we get in this group. This is one of the things okay, again, I've spread out the answers. So this is a good group to talk to because the opinions are spread out through both of these questions. So I come from the Hamilton Eye Institute at the University of Tennessee, and here we go in foreign bodies. And now I'm going to, after the 2 cases, take you a tour in foreign bodies. I have no financial interest disclosure to give. I have in the past, and what I've done is give all the money to charity. Orbital foreign bodies, let's talk about it, is primarily penetrating injuries. There's a subset, orbital anatomic considerations, and we'll go through that. And then the special thing that we as ophthalmologists need to understand is imaging and what we can do with that. The fourth thing to consider is foreign body characteristics, and we'll get extensively into that. And then the last is how to go after these things. If you're an ophthalmologist and you deal with trauma, you understand the physics of trauma injuries, and the physics have to do with mass and velocity. If you notice this equation, E 1/2 mv squared, mass is a single item, but the velocity makes a big difference because it is squared. The ability of a missile to penetrate into the orbital tissues depends on velocity and mass. Remember that. And basically, when you have a projectile, you get a few things that occur. One is you get a permanent cavity by the path of the projectile. Then you get a temporary cavity by the image and shock wave that is imparted into this. And just to give you a real example of what a high velocity injury, a high velocity bullet, or high velocity projectile will do, not only does it give this a permanent cavity with this, in this case, a deer rifle or a large animal rifle, the injury path is this wide. And if you don't think it really occurs this way, all you have to do is look at the cavitation that has occurred in the CT scan. Even though there was a single path here, the injury goes from very medial to very lateral. The destruction is quite significant. Optic nerve has been not injured directly, but it's injured indirectly from all the shock wave. The second is low velocity injuries, and this happens to be a pellet gun injury. And this pellet gun put the pellet, a lead pellet within this orbit. No significant shock wave, no significant external trauma outside the pellet itself. So the question then comes is, what do you do with the pellet? Because there's not that much significant associated injury. There is an interesting thing that has occurred in war, and it also occurs in civilian life, and that is the number of ocular injuries has continued to increase, and we will see more and more of these because of our active society. In the U.S. Civil War, the number of injuries that occurred that took a soldier off the battlefield was 0.5%. As you can see in this group, Desert Storm had 13%. This had to do with body armor and protection. The same thing happens in sports when people wear headgear and all the other things that occur with this. It's protection, but the protection often isn't good enough for small injuries. This is the classic example of what has changed over time and what we've had to do. This pair of glasses used to be issued. As you can see, there's injuries can get around the side of it. It used to be called birth control glasses because none of the young people would wear them. They weren't in style. I think they may be back in style now. A company called Wiley X, I just brought this because this was one of their demonstration pieces. This is an IED piece, and this is 3 millimeter thick polycarbonate. This injury would have been quite substantial if it hadn't been for the protection associated with this. But the point to be made is the frequency of high velocity or medium velocity injuries is increasing, not decreasing. Wear your protection. So the next section I'd like to get into is orbital anatomic considerations. And if you think about an orbit, it really is a compartment like many other compartments within the body. It has a set of muscles, movements, nerves, blood vessels. This compartment is fairly contained, but different things penetrate into the compartment. But because of its periosteal lining, it does do certain things. Also, because of its bony structure, it does certain things. Extraocular movement depends on the muscles and the function of what's called the orbital septal system. And I'll show you a demonstration of that. The optic nerve itself has unique characteristics. And the other, in the full face, the orbital volume maintains globe position. So if one orbit is out of place compared to the other in some type of injury, the globe position is affected. So here's our compartment. This is, everybody talks about the orbit as being a pyramid, and it does have a wide base in the front and then goes to a back to the pyramid optic canal we were looking at not too long ago in the first case. But truth is, it widens and just past the aperture, and then there are many areas that penetrate through this, and if you'll see, it's not exactly a pyramid. It's got round contours. From anterior to posterior, the floor goes up 20% anterior medially, but it is literally a cone, and it's fact, and that impacts orbital foreign bodies because they're directed to the posterior aspect, as we saw in our first case. The second piece I'd like to really discuss is what's called the orbital septal system. And Leo Cornef in the 1970s described this, and what he did was thick sections of the orbit to isolate out a septal system that he saw. This is a series of photographs from his original article, or drawings from his original article, in which the recti muscles are within the orbit, suspended in their position. And if you'll notice, there's a septal system that goes out to the periosteum and suspends these orbital pieces throughout the entire orbit. Jonathan Dutton was good enough to get his artist to really kind of draw this in a three-dimensional type drawing instead of this cross-sectional drawing, which shows that there's a septal system. This system must be maintained to maintain balance of the extraocular muscles. It also acts to baffle and change things as far as injuries that enter the orbit. It is often why extraocular muscles are greatly affected, even though the muscle's not directly affected. The septal system's injured. Like an orange on the side, the septal system just has different compartments that you can see, and like an orange, each one is somewhat separate from the other, even though they're part of the whole. The full orange, or the full orbit, is the big compartment that we deal with. The optic nerve is special, and we all know this quite well, and the fact that it has dura associated with this. And here's the nerve suspended with its arachnoid and pia. CSF goes through this system. This becomes a second compartment within the orbit in which injury can occur, and as in this case, the injury occurred through the optic nerve, and as you see, hemorrhage came from posterior to anterior in this particular individual. So again, a unique compartment in the body. It requires special attention, and when you see things in the retina, dilated fundus, you get information as to what's going on. So now let's move on to the types of foreign bodies, and the major definition of foreign bodies, the major division of foreign bodies comes into inorganic versus organic. And so the list of inorganic foreign bodies is primarily metal, glass, plastic, fiberglass. And what happens is because of all these projectiles that come through, we're always trying to determine, has this projectile entered the orbit, and is it really there, and where is it? This slide delineates size, location, and composition. This is a radiology breakdown of what we should see with each one of these. Metals, as you'll know, because their increased density, can be found with very small, minimal sized pieces of metal that can be tracked within the orbit, and we all see this. Glass is much different. The variation in the size, as you can see, from 0.75 to 2 millimeters minimum size that you need. It's easier when they get larger. Depends on and this slide says lead content. It's really heavy metal content. Anything that has some density that's metal, most glass is made with a base metal in it. Lead is the most common, but there are others, cobalt, etc. And so you're looking for the metal that shows up with the glass. Plastic and fiberglass are radiologically inert, or the answer is looks like air. They're not there on the scan. There's no moisture within them. There's no configuration. So I call it linear air, or it looks like air. So this is the basic tenet in inorganic foreign bodies as to what you're looking for. Classic easy example is a shotgun blast from a hunter that got hit in the face. And what he has is multiple foreign bodies throughout, which you can see, and they're easy to see on a plain film. I mean, they're all over the place. You can localize them by a number of different techniques, but you know exactly where they are. Metallic foreign body. This is a little bit different. This is glass. So the question is my residents ask, well, where's the glass? And the answer is it often looks like the bone associated with it. It has a different configuration. Look at this. And depending on the density of the metal, it will tell you where it is. And some cuboidal glass, like windshield glass, is very difficult to see. And so this is glass. I'll give you the example that you need to see, and that is this glass has been taken out of this individual, and this has some lead within it, and it's yellow glass, and it's fairly easy to fix. You have to go ahead and pick it out, but you can re-X-ray or re-CT scan and find out whether you've got most of the glass. Do you need to pull all of the glass out? That's a question we'll get into in a minute. Here's an individual that walked in a shooting range in which a crossbow unfortunately was discharged when he wasn't cognizant of what was going on. And this crossbow injury caused a significant injury here. In my slide, you can see the point on the crossbow. But what else do you see is this linear air looking thing on the X-ray, and what that is basically fiberglass. Fiberglass, inert, doesn't look like anything but air on a CT scan. So what you see is this individual that has received a deadly injury through his orbit into his brain, with the fiberglass shaft in there in the tip all the way in the base of his brain. An unfortunate accident, but you get the idea of what the material does and how it looks as a foreign body injury. Another easy one to pick up and look at has to do with the base metals associated with this, and this is a metal piece that was in an individual that felt that he needed to saw something and he used the wrong blade. You can delineate the extent of the injury and whether it traverses other compartments other than the orbit, and this one indeed does. It goes into the anterior cranial fossa, and this unfortunate individual received an injury from a polishing blade that came apart and basically at high speed by the drill went into the side of his face. He is doing well. It was extracted. It took a multiple team to bring them back together, but this type of injury gives you an idea of what you see on imaging. Let's move on to the other group that you need to talk about, and that's organic foreign bodies. Organic foreign bodies really should be divided into two types, and it has to do with how much moisture they have in them. The moisture associated with a pencil lead or a pencil is very dry wood. It has a very specific characteristic. Wet wood, such as this bamboo, shows up entirely differently. So let's explore this problem of wet wood, dry wood, because that's the first question as an ophthalmologist asks is, okay, it's a wood injury or it's an organic foreign body. What type of wood is it? What is related to it? So CT scan evaluation of somebody with dry wood comes out as a cylindrical lucency. This is clear. It really has no fluid within it. Again, it looks like linear air. Their problem is that it doesn't separate pieces well, and you can get multiple splinters that show up as one piece on a scan. Hydrated wood is even worse. It's isodense to fat. Really difficult to find, almost impossible to find. And so when you know you have a hydrated foreign body, a wood organic foreign body, then you know you've got a real problem in isolating this lesion. That goes back to our second case and what everybody asked about. This is a 15-year-old that was ejected from a vehicle and hit a tree. The tree happened to be a dead tree with dry wood, and they came in and showed me the scan, and for those of looking at the scan, you can see the orbital fractures. And if I can get there it is. And here you see the multiple orbital fractures, the lateral wall's fractured, the anterior orbital rim has been fractured, the floor, medial wall, but what we have here is linear air. We pulled 6 dry wood fragments out of his maxillary sinus. Linear air, knew what the foreign body was, you know what you're looking at once you've seen it. It looks like air in the maxillary sinus. It does not look like that at all. So let's go a little deeper into the problem of organic foreign bodies and identifying them. Most of these are what we call impalement injuries, and this is indeed one. He fell on a stick after running away from the police. When he did, this impaled him and is here. So you see linear air, and the nice part about it is it sticks out the other side, so you know you got a piece of wood. The thing is if you look a little closer, you're going to see more than that. What you have down this medial wall is more linear air. So is this a foreign body or is this not? The first service pulled this out, and I'm going to do this one first. It has to do with, there it is. Again, this is the foreign body. It looks like air and the rest of the thing. This is wood. This is dry wood. So the first service did this, and they pulled it out, and that's a scan, and I'm going to get back to that scan. And they thought they did a great job. They told me it was all over, and I looked at the scan the next day, and I said it's not all over. The reason I'm saying that is if you look back along this wall right here, here's the linear air. So we had to go back in and explore this orbit and get the other piece of foreign body out. This is a significant problem, so you're looking for retained foreign bodies that had fractured. Well, this case got much more complicated because in a couple of days he became more a problem and he was more symptomatic. And so I went back and looked at the original scan. Here it is low in the maxillary sinus, and if you'll see something, look at this item right here. This is in the infratemporal fossa. Being in the infratemporal fossa after being impaled through the orbit, this is an unusual place for air to stay. So I asked him to scan him again in 4 days. What happens is the air changed. Look at the air in the maxillary sinus, look at the air in there. It's all shifted around. The bubbles are different, the blood's different, but this thing's the same. 10 days, identical. Air doesn't go away, should absorb, it should go away. This did not go away. I then did what's called a lung window, and I'll get into that in a minute, and looked and said, okay, where's the foreign body on the original one? And you can see that lung window shows different than air. I'll explain why in just a minute. So the foreign body looks different than that. The standard orbit brain foreign body doesn't show this, but if you can do the other, you can see that. And if you look at the original, I'm losing my marker, there it is. There's the retained foreign body that we had to go after they took the original stake out. There's the pieces that were there that we knew were in there. But lo and behold, I took the lung window on the CT scan and looked at this piece and look at it. It's not air anymore. It's different. But this is the piece we pulled out of his infratemporal fossa. Excuse me. It had been the main fragment that we pull out of his lateral wall of his orbit, plus the big stick that was associated with that. But there they are, put back together. And here's why. CT scans are on what's known as the Hounsfield scale. When it was developed in Britain a number of years ago, the scale goes from 1 to 4,000, and it has 1 to 4,000 shades of gray. Water is 0, air is minus 1,000, bone and the others around 395, 4,000. That sounds good. You ought to be able to pick it up. Well, there's a problem. The problem is this. Every X-ray scanner only shows 256 shades of gray. Therefore, you're taking 4,000 to 5,000 shades of gray and picking 256 shades to look at. So you have to choose it in a window of what to do with. So what the presets did was they set bone from 500 to 4,000. Therefore, you can pick up all the things associated with this. If you narrow that window down and take the highest window at 2,000 instead of 4,000, what you get is a 500 to 2,000, and all of a sudden anything that is not truly air starts looking gray. And so I'm going to back up a couple. Gray. You see my gray piece? That's a lung window. You can do it by changing the numbers, but my recommendation is go to the presets, put a lung window on, look for organic foreign bodies, compare it to linear air. So that's my pearl for the day of trying to find the 256 shades of gray that is buried in the 4,000 Hounsfield units that you need to know about. Now, let's talk about green wood. And this is the great dilemma. Another impalement injury. This is a stake. Came through here. You know it's a significant injury in the fact that the lateral sphenoid wing has been disrupted, the bone's been pushed aside, and we know something's there. He said, well, I pulled out the stake and it came out and there's no more foreign body. Now what you have is wet wood, green wood, and is there a foreign body retained in there or not? And the answer is, I can't tell. And if you look at it by CT scan, or MRI, again, you just can't tell. The injury's there, the material's all there, but you have no idea what's going on. What happens is a couple of days later, and this is the key to this, 3 days later, guess what happens? The body tries to reject the foreign body. It creates an inflammatory response, and you get an encircling inflammatory response around the foreign body. The next thing you know, what you have is a foreign body that is glowing or ring sign, and as this coronal shows, it's a ring around the foreign body. You can identify the foreign body by the inflammation. So the key to this is green wood will show up through inflammation. It may not show up at the first scan, but you need to repeat the scan 3 to 4 to 5 days later. If you suspect one, you don't just let these people go. You rescan them or you watch them. So back to the other ones, retained foreign bodies, dry wood with MRI. We did CT scan and it's similar. This is MRI, dry woods, hypointense on fat to T1 and T2. It's a dark cylinder or circle, shows up very nicely. Here's a wood. This was a hunter that fell, again, impaled himself and said, I took the thing out. He went to the emergency room. They sewed up the small laceration and left this piece in there. So that is what he has. MRI with retained organic foreign bodies. MRI shows green hydrated wood. It's iso-intense, but it begins to glow with gadolinium after inflammation sets in. So what you're looking for, if you can't pick it up on the first time, don't give up, rescan them in a few days. You'll begin to show what's there. So the reality of imaging, because of this technology of the size of the image and the type of foreign body, 40 to 50% of all organic foreign bodies in the orbit remain unidentified before surgery. We reported 24 of these in 1999. Another group, as I noted below, reported about 40 of them in 2010, found essentially the identical problem that we said, and it has not changed. So let's go a little bit into the characteristics of foreign bodies. Inorganic, and the thing I alluded to is inorganic foreign bodies, glass, plastic, metallic, are usually inert and they're well tolerated. We reported that in 2004, and we have another group that's coming out in the next year or so. 55 retained metallic foreign bodies, up to 40 years in place, no real problem. So our recommendation stands today as it did in 2004. The interventional management of this type of foreign body depends on the resting location of the projectile causing pain, inflammation, or other functional problem associated with it. Metallic foreign bodies that are not inert are a small group. Pure copper, as we as ophthalmologists know, gives significant problems with retina problems. Also in the orbit, it's very reactive. It's a metal that requires removal just because of its activity associated with it. Similarly, iron, old iron rust, it causes surrounding inflammation. If it's a very small piece, it will be eaten up pretty quickly. If it's a large piece, it's going to need to be removed. Lead will degrade. You can get lead poisoning. However, the lead must be without antimony. This is a stabilizer. It's used in all bullets and in most hard lead, not the solder lead. So if it has been treated with antimony, it is a stable inert piece and can be around forever. Doesn't cause problems. Lead poisoning only comes from pure lead that has not been treated. Classic question many people ask, and this is the children playing and BB guns or air guns. What do you do about a BB injury? And it turns out BBs, you'll have to check the composition, but the one here that's called a copperhead is not truly copper. It's a steel core with zinc plating. It's got an acrylic lacquer coating. They're very well tolerated. So there is really no need to go after a BB unless it's impinging on the eye itself, the globe, or affecting extraocular muscle function. And we have a whole group of BBs that we just follow slowly. I mean, we just follow without any intervention. So let's go back to our case one. Case one, the 55-year-old male struck low of the eye, had the pellet. You saw the pellet, and here we go. Here it is. It's pellets in there. There it is, right back in the optic nerve. He's no light perception. It happened right at the time. So I'm going to ask the same question again. Case one question. To care for this patient, would you recommend A, exploration and removal of foreign body, B, observation, C, steroid therapy, or D, MRI scan to access the optic nerve? So let's put the question back up and ask it again. And I would like to wait just a second, and we're going to get to some questions after it because of the function of this, and I'm delighted to answer questions for the entire group. as you send them in at the end of the lecture. They've given me a tight timeline, so I'm trying to move right ahead. Let's see what we get. And then what I'd like to do is go down the question and why we thought about each of the answers. So while I'm waiting for the answer to come up, exploration and removal of foreign body, 22% felt that it was still indicated. And I'll take, everybody got away from the steroids, which is interesting, and MRI is a 33%. And I'm going to go with each one of these, and let me get to this thing and close it. And I'll take exploration, removal of foreign body. If somebody's instantly no light perception and it's in the optic nerve, can you regain vision by decompressing an optic nerve? And I'm afraid the literature does not hold true on this. Can I fault anybody for thinking about it, knowing it? I cannot. But if you give me what I call evidence-based medicine, there's not great indication to do this. It's in the optic canal. It's right at the base. The injury's been done. It's over. Observation is what we elected to do because we didn't feel we could benefit the fellow from other materials. The other one interesting is steroid therapy. There have been two major studies, one on traumatic optic neuropathy, which really didn't show any difference in the treatment of injuries. And then there was the English crash study for intracranial injuries of 10,000 people, and they showed some downside to using it in people with other significant injuries. So I caution people for steroid therapy. Can I fault somebody for using it? No, I really can't, but the jury's still out. And then the last one's the most interesting. MRI scan to access the optic nerve. This person in the United States was duck hunting. If you know the rules of duck hunting in the United States, this is a steel pellet, not a lead pellet. It's magnetic. This fragment will move by MRI scan. So it is probably contraindicated if you know the material you're dealing with. This is steel. You are going to shift this. And the real question came to us is, say he has other injuries and needs other MRIs in the future, would it be benefit to go back to A and explore and remove the foreign body because he needs MRIs? And we have entertained that. We have not done it. He knows he has a steel piece within his orbital apex, and if he had an MRI, there is a significant risk that this may shift. So let's go to our next group. The 9-year-old male fell on a broken broom handle 2 months prior, wound removed, wound healed over 2 weeks, new onset of swelling, pain over 5 days. So second question, let's do the question again. Your next action is A, repeat an MRI. A repeat MRI is needed to find the retained foreign body. Antibiotic treatment should clear this. Or C, exploration immediately is indicated. So the first, this is my question, what should you do first? And so I'll see what the group says. And I'll wait on this one because I'm interested to see what kind of discussion the discussion has shifted the group. That was dry wood because it was a broomstick, but it didn't show up. And we should see this. And I guess everybody knows now that the antibiotic's really not going to clear this in most cases. It still might with this look. Agreed, the group's got it. 73% said a repeat MRI is needed. And the reason is the inflammation will set in around the foreign body. It will outline the foreign body. It will give you a big thing. Exploration was immediately indicated after the MRI was done, so I agree with those two answers. And to go back in it once you've identified where the foreign body is. So here it is. That's the original wood piece. Here's the 4 more pieces of the splinters that were found in his orbit. He is now without swelling. The foreign bodies have all been removed. He's doing much better. But I felt this illustrated the big problem with these things is these wood pieces will splinter. Organic foreign bodies are a significant problem. So organic foreign bodies, usually it's trivial trauma. It breaks off and somebody says a small wound site. They suture it. Most of these are long, thin structures, twig, pencils, things that classically will move. It strikes an orbital wall. Remember, we talked about that orbital contact, and it penetrates the thin walls that are directed toward the apex, and look out for fragments. Organic foreign bodies, delayed inflammation, repeat imaging, understand the characteristics and the foreign body type. So let's get on to the extraction. What happens with this group of people is that as you try to get to the foreign body, it tries to move deeper within the orbit. So my answer is trap it if possible. If you can get a ribbon, retractor, or something around to the back of the foreign body and then dissect to it, you've got a much better chance of getting all of it. I will follow the track, but I will try to trap it. The easy thing to do is to find something that you can get behind it through the conjunctival surface, or something to hold it, and then I'll follow the track along a tear duct probe. Expect multiple fragments and look for them. Don't tear up the orbit or tear it apart, but do that. The other thing is to back out if you think you've done a good job, and then wait for the inflammation and repeat the MRI or repeat the scan to see if you can identify this. What's coming down the pike? Stereotactic localization is out there. It involves either preoperative MRI or CT scan. It's a system of intraocular localization of surgical instruments superimposed on a screen, so you can isolate it. The only problem is it accurately locates to bony landmarks only. So soft tissue intraoperative changes cannot be tracked. So if you move the foreign body, its shift, it will get you into an area, but it will not guarantee that the foreign body will not move on you. And that's the downside of using this. What can you do inside the operative suite that help you localize it again? There is C-arm localization that can be used for metallic foreign bodies. This is a metallic foreign body here. C-arms are used by the orthopedic people. You can pull it into the operating suite and localize it, especially something that shows up fairly easily with this. And it gives limited soft tissue differentiation, but you can really isolate where, especially if you put a localizing instrument next to it, you know where you are in 2 or 3 dimensions. Evolving technology is intraoperative scanning. And both of these, whether this is the MRI suite, which is in our children's hospital, this is the MRI suite where you can literally put a surgical procedure together, get down, see if you've still got something, put some instrument in that are non-magnetic, and then rescan them in the operating room to look. I have not used that, but it's there. The other is the MRI here is, the CT scanner here is a small transportable CT scanner, and it can be used intraoperatively. So question number 3, since we revisited the 2 questions, one is characteristics. Penetrating injuries are increasing frequency and type. The orbit is a unique anatomic structure that affects the management of foreign bodies. Composition of the foreign body requires individualized treatment, or the last answer is all of the above. So I'll let everybody answer the question. And we'll see what type of answer we get. It's been very good to see shifts in the other one with the discussion that are there, what to do. Okay, that was too easy, everybody got it. Let me get my screen moving again. Orbital engineering requires knowledge of foreign body characteristics, knowledge of foreign body timeline, knowledge of characteristics of the viewing window of the image display, or all of the above. And we'll see what we get here. Again, 93%. All of the group has changed their view on these, and I hope really I've been able to make everybody think a little bit differently about it. I just went through those 2 things. The intervention is really evolving significantly. And as we get complex foreign bodies, as these scanners will allow us to do this intraoperatively, we may do a much better job with some of the deep foreign bodies that are associated with this. So I'd like to thank everybody for listening to me. Now I think we'll go to a question session. So please pose your questions into the group and we'll begin to answer them. And this is an interesting scenario for me. Without being able to talk back and forth, I like to hear what the group has to say, but we'll see if we have any questions. If we don't, well, I've enjoyed the conversation with everybody, or the more of a conversation back and forth, but I think we've changed some people's thoughts about orbital foreign bodies a little bit.
So Dr. Fleming, if you want to stay on for a few more minutes, we can see if people, if you want to stop sharing your screen, it looks like we just got our first question in.
Very good. I'll stop sharing my screen. Do I need to click on chat?
You can click on Q&A.
Very good. Somebody asked that I go over the temporal cavity picture, and somebody asked the second question was the use of a magnet and foreign body removal. I will take the magnet first because it's the easiest one. If you can get the magnet between the foreign body and you without the globe or some other structure in between, absolutely use it. You can use it to pull it out. It was used many years ago in intraocular foreign bodies to pull it to the surface, but that's it. I'm going to go back to the pictures when I have to pull it back up in a minute, and I'm scared that if I do that right away, I'll lose my connections here. A bit off topic, I'll read this next question. A bit off topic, but I would like to know how will a green and dry wood intraocular foreign body appear on B-scan? It does pretty well on B-scan. It has to do with the internal reflectivity on B-scan. Both CT and MRI do work with water, and B-scan does not. So it's going to give you a little bit different characteristics. So go back to the B-scan characteristics. It's got an interface on the system. I would guess that the interface between the green and the fat, because it's iso-intense, would give you a little bit of a difficulty, but it may well be helpful. It has not been greatly helpful me in the past. I've done better with CT and MRI. I've got a number of questions, so I'm going to my question with regard to organic foreign body: do you insert a drain at the conclusion of surgery to lessen the inflammatory edema for the next coming days postoperatively? I usually do, because it's going to cross there. I usually leave a drain 1 day, maybe 2, not that long. Again, the inflammation is usually associated with the materials, and if you wash out the track a little bit and get the little fragments out, it'll usually do pretty well. How do you check the intraocular foreign body with penetrating ocular trauma? That comes down to you're looking for something that has a track through the globe, which is really a different subset of questions for us. You can pick it up in an MRI or CT, but also you need B-scan to look at and to do a dialytic fundus exam, a good eye exam for that. As a routine, would you use antibiotics routinely pre and post operatively, and would you tailor them to the kind of foreign body using antifungals or organic foreign bodies such as wood and or plant material? The answer is, for antibiotics and organic foreign bodies, yes, I would do it. I haven't used antifungals as an original. You can culture the material and see if you get anything. All of these are dirty. The organic foreign body, because they have multiple pieces of bacteria, cloth, all types of things are brought in with this. Usually they're low velocity injuries, and so they bring material in with them. The inert ones, if they come in at high speed, they're usually sterile. Bullets, etc., are not that much unless they go through a shirt or other material and bring drag parts into it. If you see a foreign body that has a dirty track, we wash it pretty profusely to try to get the fragments of wood or whatever is out of there. What are the non-surgical options for managing not inert foreign bodies? Observation is the one we use. I mean, non-inert foreign bodies. I was thinking inert foreign bodies. Non-inert foreign bodies. If you have this person can't go to surgery and you can't kind of open the wound and kind of bring it out or whatever, there's a group of these that the purulent infection will force it back out. And you've seen this in other parts of the body, the hand or the foot or the leg. They step on a piece of splinter and it's there for a week or two, and then it literally pusses out and then it's spit out. The problem is that orbital septum system gets destroyed by the acute infection. So they're not good options in an orbital area because you affect the function of the eye. Do you put some antibiotic in powder form in the foreign body tract postoperatively? I have not. I would be interested if somebody has any evidence-based medicine that shows that. I mean, we as ophthalmologists put topical antibiotics in and around the eye all of the time. I would not put ointment in because it can get a foreign body reaction, but and you can get some tissue penetration from that, but I just don't know good studies associated with it. Can you leave some types of intraocular foreign bodies? If it's inert, intraocular is a different material. Yes, you can. I reported a case with Dr. Hamilton, who I'm from the Hamilton Eye Institute, that had a piece of rock in his eye for 52 years until the rock worked its way loose and started floating around in the eye, and they wanted it removed. Here's one. In case of severe edema, what's the optimum time of surgery? And that's an interesting question. We'll often wait 2 to 3 days. With an organic foreign body, I'm not inclined to wait a long period of time. Are there any X-ray equivalents to lung windows? X-ray, you pose a good question, and I really don't have an answer for that unless you just turn the amount of penetration down and try it. I've not read anything where it's been used. Okay, the next one, a patient with a metallic intraocular foreign body, is it near the inferior lateral wall of the orbit after penetrating globe? How do I manage it? I'm not worried about the foreign body in the orbit. It's more the, excuse me, penetrating foreign body of the globe. Deal with the globe and let the metallic foreign body sit. When leave a foreign body and don't remove it, back to the same answer. If it's one of the inert materials and it came in, then I'm not going to go after it. It's inorganic foreign bodies, inert stuff, we watch them. We may cover them with some antibiotics if we think it was a little bit dirty, and we just watch. Is there a place for steroids in the management of patients with intraorbital foreign bodies to adjunct to the surgical intervention? There may be in the acute inflammation after the infection's been treated with antibiotics and you're trying to calm down the orbit. If you're a believer in that, then I would do that. Okay. I'm going to attempt the last one, the temporal cavity, and let's see if I can get back to my PowerPoint presentation and do that and get into shared screen again. I'll show you the temporal one. I'm going to shrink this. I'm going to close this question session. This is the infratemporal fossa. This is this lung window, and you see it's gray right here where the air is black. gray, air is black. Those are the two. And if you look at it, and back to the standard bone window, we were looking at a bone window, and you see air, and you think it's air, but it's not. It's the other. Excuse me. So there it is. There it is. And this is over a 10-day period. Air should absorb, and it did not. So you go back and look at the window. There's black air, and that's the lung window, and you see it as gray. And if you look at this one, again, gray, it's not air. And this one absolutely is not air. So we had to go in the infratemporal fossa to get to it. Q&A, do I have any more? I did the temporal cavity. At a subdivision level, what test would help us to detect retained foreign body apart from evidence swelling? The problem is what you have to do is wait for the swelling. You can MRI them in 3 to 5 to 7 days before you have swelling. You'll still get the inflammation. Even though it's not exteriorized, you still will get some inflammation. If it's not there, we've had one thorn that was in 5 years and then finally got secondarily infected, and I don't know why it went 5 years, and then we were able to find it. And then one of them is, sorry about my cough, what are the applications for the orbital septal system? I put it in there really to discuss the injury that occurs by a foreign body going through the orbital septal system, and has to do with the second piece is if you're a surgeon going after the foreign body, what you have to be is cognizant that there is a septal system, and you're trying not to just go in and take a scissor and spread and break the septal system while you're trying to find this foreign body. You're trying to do minimally invasive surgery associated with it. Back to the lung window, I'm thinking about this question. When you do an x-ray, you either penetrate it very dark or very light. I'd be interested in, this has not been done, is to take standard skull film and shoot it at different densities and see if it can make a difference. And that's an interesting question, but I can't give you a straight answer. Okay, I think I've answered all the questions. I have no open questions. I would like to thank everybody for joining me, and have a wonderful afternoon or evening or whatever time in the world it is. Oh, I have one more. I have a case of lost vision after trauma to an optic nerve canal. Can I do a test to determine if there is a catting in the optic nerve, a VEP, etc.? This is a timeline question. What you have to do is wait and see. And I tell people I don't give up on optic nerve injuries, but I give it time, let edema go down. If you use some steroids, fine, but there's not great data, as I alluded to earlier. But just give it time and see what you can come up with. Thank you very much.